Thank you so much. So this is Leah Persky with JFCS, Mark Hoffman with JFCS. They are the subject matter experts here. I'm going to stop talking so that we can listen and learn from them.
All right, great. Thank you. Thanks, Matt. Nice to be here. Nice to see all of you. Mark is the subject matter expert here. So I will take just a moment to introduce him. My name is Leah. I'm the Family Life Education Manager at JFCS, and I facilitate different trainings. So we're happy to be here with you all today. So Mark will be our presenter for the day. He has a master's degree in social work from the University of St. Thomas and St. Catherine University. He has more than 10 years experience in mental health, working with adults with anxiety, depression, personality disorders, trauma, severe mental illness, and chronic illnesses. He loves to work with people through problem solving and self-discovery, and he believes in collaboration to find healing and personal growth to help solve problems that people are facing. So we're very happy to have him here today. And he has his PowerPoint presentation, which he will share with all of you, and we're happy to share that with you as well. We have the chat function enabled in Zoom, so you will be able to use that if you have questions that you would like him to address as we go through the presentation, so you can feel free to put those in the chat, and I will help to alert him to those questions. And we'll have some chance for small group breakout sessions for some questions as well. So that will be the general plan. So take it away, Mark. Thanks so much.
All right. Thank you, Leah. Well, thank you for having me today. This is a pretty important conversation and discussion to have. I think that when we talk about suicide, I think it's something to be taken seriously, and I think sometimes we need to demystify it a little bit as well. I did want to say, just in terms of this as a subject matter, it can be pretty challenging for people to talk about, to listen to. Do what you can to take care of yourself. Self-compassion, whatever you need to do for self-soothing. If anybody needs to bow out for a little bit and breathe a little bit, nobody's going to ask any questions. And oftentimes we see suicide differently from other forms of death. Survivors tend to have a different set of feelings than they do if somebody dies from other means. And I also wanted to talk a little bit about language with suicide. Traditionally, people have mostly, the phrase commit suicide has been out there for a long time, and I tend to try to avoid that phrase because I think it increases the stigma about it. Stigma is a complicated piece of this because there is a little aspect that some people are avoidant of thinking about suicide because of that stigma, and also sometimes people are avoidant of talking about it because of that stigma. And that's the piece that we're really concerned with in terms of stigma and suicidality, because we want people to talk about it if they're feeling like it. Some other language that's been used for it is completing suicide. We've moved away from that one as well. There have been concerns about that. That's kind of can be seen as a positive spin on it. So typically, I say die by suicide. So as language change, it's always a process of adaptation there. So. These are objectives for today. We want to learn about the factors to recognize a life-threatening mental health crisis in those that we see. Identify steps that we can take to help keep them safe. Increase awareness of resources and reduce stigma related to mental illness and suicide. So Leah, can you launch the
Yeah, I'll launch the poll. And also, Mark, can you put your PowerPoint in the full screen view? So if you go to slideshow and then from the beginning and
Okay.
like the slideshow tab at the very top of in the orange part of the screen. There you go.
Is that better? Okay, thank you.
That's good. Thanks. All right, so I'll launch the poll now. All right. Able to see that, everybody? Yes? No? You see the
Yes.
poll? Yes, okay, good. All right, looks like we're at about 92% of people voted. So in terms of the results, we have 38% of people saying that they have no experience talking to someone who's thinking about suicide. 15% said they've talked about this once before, a few times, 23%, and 23% said yes, many times.
So it looks like a range, quite a range. So as we progress, we'll get to some of a little bit of, let's see. There we go. All right, are we? Okay. There. So we're going to have some breakout questions to kind of get everybody's juices flowing here. Some questions to talk about are, why do you think suicide is difficult to talk about? Does getting psychological help or treatment have a stigma associated? And if so, why do you think getting help to deal with suicidal feelings has a stigma? And how do you think we might work to erase that stigma? So Leah, can you set up the breakout sessions?
Just give me 1 second and you should all get an invitation in a moment.
All right, thank you for any, and perhaps we can, through the chat, come up with some of the things that came up in your breakout groups.
I can share something. I was just mentioning that it's interesting that I think some parents don't talk about mental health with their own kids.
Mm-hmm.
And maybe things just get swept under the rug or whatever it may be. And I think that can be confusing for children that are feeling sad or scared or anxious.
Yeah. So having important adults, parents, modeling being able to talk about it.
Yeah.
Yeah. Some things like shame, that a lot of people are feeling ashamed of talking about it, especially if they're experiencing it, because they maybe don't know that other people also experience it, or lack of understanding. Any other notable things? Okay. So I think it's important to start to learn what the signs that we see that might be indicators of significant mental health crisis that could be life-threatening. And one of the things that I think is important is that that it starts with a relationship. So when you know someone, you're much more likely to know when their behavior changes, because you know what it was like before, you know what it's like now, and what that difference is. It also gives them the opportunity to trust you. And that is a pretty important piece. It's a greater chance of them sharing or answering your question honestly. Also, just some of the basics, knowing somebody's lifestyle. Do they hunt? Are there guns in the house? If they're hunters, there are probably guns in the house, and the evidence is overwhelmingly shows that suicide attempts in which a gun is involved are much more lethal than any other means. It's helpful to know who lives alone, who's isolated, who has a support network, and who doesn't have a support network. So looking out for those people who are not getting the support that they need, especially in these times where we're all more isolated than usual. And a nice bit of language around signs of suicidal crisis that I came across in a training that I was in is seeing them as invitations to talk. Somebody's probably not going to explicitly endorse that this is an invitation to ask them about suicide, but the more that we see that as that, the more likely we are to ask, and the more we may realize that it really actually is an explicit seeking of help. So it's better to assume that that's what it is. So things like increases in substance use, withdrawal, increased mood swings, increased obsession with things like death, talking, writing about death, giving things away, settling affairs, things like that. Sometimes if somebody's been really depressed for a long time and they suddenly have a increase in better mood, like they're not as depressed all of a sudden, sometimes they may be seeing that might be related to thinking and deciding to attempt suicide, and that their uplift in mood is seen as part of wanting or seeing the light at the end of the tunnel, and from their perspective at that time as an end of their suffering. And I think it's important to understand suicide as an attempt to end suffering and end pain, more than somebody's intent to die. Oftentimes our judgment is impaired, and it's hard to see what the other options are in terms of finding finding a solution to the pain and the suffering that we're experiencing. And those are some situations where suicide can be more likely. A common myth is that it can be dangerous to ask somebody if they're thinking about suicide, because it might plant the idea and make them suicidal. There's no evidence that supports this, and plenty of evidence to suggest that it's important to ask, because that's where we can actually do something to intervene. Ask and be specific. Avoid euphemisms. You don't want to say, "Are you thinking about hurting yourself?" Sometimes people engage in self-harm, and it's not a suicidal gesture. Sometimes people don't want to feel pain, so they're like, "Well, no, I'm not planning on hurting myself." So they're kind of skirting around the question. It's important to be specific. So identifying it as part of that, what some of the signs that you're observing, and explaining that, sometimes these are signs that somebody might be thinking about suicide. Are you thinking about suicide? I think it's important to understand the range of what we think about in terms of suicide. There's a range between suicidal ideation, suicidal intent with a plan. So sometimes think about wanting to die, but they don't really, they really don't want to do anything actively to make that happen. That's a passive suicidality. It's more of a long-term sadness that needs to be dealt with, but it's not an emergency situation. Sometimes people fantasize about killing themselves. What would happen? Who would respond? We call that suicidal ideation. Also with that, sometimes people have just thoughts that pop into their head and they're like, well, I'm not really going to do that. But I do sometimes think about it because I'm, I find myself starting to think about it, and they don't necessarily entertain the thought for very long. Sometimes people want to kill themselves, and then sometimes they want to kill themselves and they have a plan. And then the question is, do they have the means to do so? How lethal is the plan? And I would like to say that in terms of assessing the lethality of a plan, that if guns are involved, that's very significant. If they're talking about a medication overdose, I don't want to be the one to assess the lethality of that plan because I don't have the medical training to know that. Some things that might seem like they are pretty innocuous in terms of lethality because they're just like Tylenol is available over the counter. An overdose on Tylenol, I'm not a medical person, but I anecdotally have heard that it can be a long process that can be lethal after and irreversible at a certain point, but not immediate. So I do not want to be in the business of assessing whether or not a medication is going to be lethal. I would prefer to leave that to medical advice on that. So looking to act, looking to help somebody who's who you've identified and you've asked. So where they are on that range of suicidal ideation to suicidal action will determine your next steps. I'd like to say that you're not assessing for whether or not they need to go to the hospital. You're assessing who you need to call for help. Sometimes they'll say they often think about suicide but would never do it. Probably a good idea to make sure that the guns are put away. Somebody else has the key. It's a good place to start planning, making sure that they have people that they can talk to, people that they can access, and start engaging in means restriction as necessary. Means restriction is things like putting the guns away, putting the medications away, making sure that they don't have access to things that they might use to try to kill themselves. Help them to access things like therapy, mental health services in general, access to to crisis phone numbers in Hennepin County. That's COPE, 612-596-1223. Got some other phone numbers here. National.
Can you send around these resources afterwards?
Yes, I definitely want to do that. Yeah.
Thank you.
I'd also point out that things like the National Suicide Prevention Lifeline, it doesn't have to. It's not like the judgment of calling 911. You have to be judicious about how you use 911. You do not have to be judicious about how you contact the National Suicide Prevention Lifeline. Honestly, people sometimes call because they're lonely. So if it's think of it as a pretty accessible option. in these cases. When you're working with somebody, it doesn't have to be that you're really worried that they're going to act on a suicidal plan. It can be a resource at a pretty low level of crisis. As the suicide risk increases, suicidal intent without a plan is that next step. You really want to actively engage with the person in accessing the mental health resources, calling COPE together, calling the Suicide Lifeline together, something like that. Where you're comfortable and where there's a lack of other services, you might want to start a safety plan, especially if there's guns in the house. I keep going back to that, but it's really important. This can include the means restriction of the guns, pills, rope, things like that. Having somebody stay with them actually is also a really helpful thing. Sometimes that can be hard to arrange. And also, I've seen situations where people have been in a pretty significant psychiatric emergency and at pretty significant risk of suicide, where hospitals have not taken them. So there's not a guarantee, and having somebody who could be available to stay with them, a family member or something like that, can be a better plan sometimes. Where there's a plan, you will want to include something like COPE. Currently, COPE doesn't usually go physically to see people because of the pandemic, but they will call and they'll do an assessment. Sometimes they will assess that, yeah, you should call 911. That may be the case. So they're also there to help you make that assessment, and they're trained in suicidal assessment. Suicidal action. This is where somebody has the means, has the plan, and is saying that they're going to try to die, try to kill themselves. And this is going to be a 911 call. This is the situation that we're hoping to avoid by intervening much sooner, because there's a lot that's happening here. When you call 911, be prepared to give the location, clearly describe the situation, any weapons that might be involved in others who are present. They're going to want to know names, physical description, any diagnoses that you might know, and it's an emergency, and you don't have to worry about HIPAA, because this is the information that is going to keep this person safe. There are situations that arise there have been times in the news. It's too frequent, but it's not. This is an emergency situation, so you do have to act. Sometimes people who have been in a suicidal crisis have presented as risky to other people around them, and they're going to be at some risk. Police will be the first to arrive, almost always before paramedics. And so, as we know that sometimes this escalates the situation. Sometimes, unfortunately, we don't have very many other opportunities, any other options at this point. So this is one of the reasons it's really important to be asking long before this becomes a situation. And the reality is, people are not going to call us and say that if somebody's calling, they're hoping that we're going to help them stop. So that's the hope. make sure when talking to the 911 operator that you're letting them know whether or not the person is a vulnerable adult, and give as much information as possible. I'm repeating myself there. It's if you've ever called 911, your adrenaline is going, and it's really hard to make sure that you have all that information ready. And they do a good job of asking what the important information is there. When I send out some resources, I'll send out some links to some I think pretty good training resources, including one that the one that I did that I think is really helpful is Living Works Safe Talk. I'll send that information out. That was a training that actually is geared towards their minimum age was 15, so they're really looking at not professionals at helping people to learn how to ask, so that more people are out there asking. So that's what they are looking to do, and it's a really good opportunity that gives you practice in terms of role playing in a really low risk situation, how to ask and try to get that practice in there so that it's easier to ask when it's really important to ask. Any further questions?
What are you seeing during this time of COVID around mental health in our Jewish community? Are you seeing an increase in suicide or other mental health illnesses? And are there any new resources or services that are speaking directly to that, either at JFNCS or that are available in the broader community?
So I would say what I'm able to see in terms of pandemic related increases is especially going into winter, and a definite uptick in intakes for counseling. A lot of that related to a combination of anxiety, depression, some family conflict, couples, in terms of people who are not getting out of the house very much, and not and kind of like this idea of being in a box with another person for a prolonged period of time, and some increased conflict there. Outside of what I normally see in terms of the clients that I work with around suicidality, I'm not seeing any specifically pandemic related increases there. From time to time I look up on the internet to find out what is out there in terms of data for increases in suicidality through the pandemic, and I haven't seen much data yet. Seems to be a bit of a delay. It's been a couple months now that we've seen some hard data for a significant increase in depression. So that my gut, while not, I don't have any data to say that I think yes. I mean, with isolation, with increased depression, and honestly, as we go through this collectively traumatic experience, I think everybody's emotions are a little bit more up and down in general. So yeah, I intuitively think that suicide is at a greater risk. I don't have any data that shows that yet. So, you also asked about new resources available. I'm not aware of a lot that has come up, but I can get that out I'll specifically look for some. Just going to write that down for myself here. I'll connect with IRC on that also, and take and referral connection to see if they have a pretty good thumb on the pulse of that. So I'll find out with that and kind of ask around, and then try to get you some more information on that. That's a good question.
You, Mark, had any experience with the texting resources that are out there right now? I know some of the teams we've worked with have used those, and we've referred them that there's, as opposed to a lot of our teams don't like to actually talk to someone, but there's a texting crisis network.
Mm-hmm. I have. I think it's definitely a better resource for some people, because I think that it's a little bit easier to share and talk. And talk about it. I don't have access to what goes on with those. Outside of, I do have a side practice that's online and has a messaging component, but it's not crisis related. So what I have seen is that from my end of that non-crisis oriented text messaging platform is that it actually works pretty well. I don't have any numbers in terms of what utilization right now is on that. I have no qualms about that as an effective resource.
Thanks.
I guess kind of follow-up question from both rabbis. Given that we are in a different physical state right now, being in COVID, and many of us are kind of isolated, are there different, I don't know, remember your second or third slide when you showed kind of things to look for and listen for, are there different ways that is occurring now that is different than we were experiencing a year ago?
Sorry, I had to sneeze. Yeah, if you're asking us specifically,
I'm asking Mark, following up from both of you.
Got it. Okay.
I'm interested in hearing what you have to say. I'm not observing anything different there, other than I would say it's harder to see. It's more likely that it can be concealed and more easily concealed.
Well, that's kind of what I'm trying to figure out is, are there things that we should be considering doing in terms of proactive outreach? Because it's easier to kind of hide and be quiet and isolate in different ways now than it was before.
Right.
You know, if you were somebody who were kind of masking your depression by going to work and putting on a smile and then going home, like nobody knows, but they would see you every day. They'd at least have a chance. And now that doesn't really exist.
Yeah, I think any outreach opportunities that you have to reach out to people like that, to reach out to people that you might not know their mental health status, but you know that they live alone, that they don't have a lot of access to social networks, that any outreach that's possible is good, is helpful, because that is exactly what would I think help us to identify those risks.
I would also just add, Matt, in light of the comment, and Mark, for what you're saying, what I am noticing more now, not only do I feel like I've been connecting with people in crisis mode weekly or every other week, but sometimes the things that they're coming to us for are actually more of a tipping point. So I actually had connected with someone recently about their potentially going through divorce, and I realized that the conversation was not about divorce, but it was that they were contemplating suicide. And I don't know if that would be the case outside of the pandemic, but because everyone is so overly saturated.
Right.
And that's what came up in part of the conversation. And so I feel like when we're connecting with people about the trials that they're experiencing, things are just that much more acute and that much more severe right now, when they otherwise might not be because their cups are just full.
Mhm. So when you were having that call, you were listening for those invitations to talk about suicide.
Yes, and that's something that I didn't when all of this started going down a year ago, right, or March or April. It wasn't something that I, was keen on initially. But there was a midpoint this summer where we had I had two or three kind of crisis suicide interventions in a week, and I realized that that's what was going on.
Gotcha. Thank you.
I just have something quick to add too, just from my work with families and work with parents specifically through parent coaching, is that making those one-on-one connections to people, like outreach individually to people, just like picking up the phone and sending an email, the best way, best way to reach that person is, and to really say, how's it going? I'm here to talk, has been helpful to me in the work that I've done, because a lot of parents, especially that I've been working with, are so overwhelmed they can't even necessarily pick up the phone to say, like, I need help from you. It's like you have to reach out to them on that individual relationship basis that you have.
Any others?
I have a question.
Yeah.
Is there, when you were saying, like, just as far as like if you had to call 911, for me, I have a certain for me, I guess I would just off the bat be uncomfortable calling 911, but like you were saying, like is there, when you were saying like to tell like the 911 dispatcher, like try to give him as much information as possible. Like I have a son, and I mean, automatically I'd be scared to call just because I have an African American son. But what would be like words to say to them to let them know, like, I mean, like he's thinking of suicide, but like how do you like de-escalate the police that come to your house? Like, I mean, I don't know how to say it. I'm hopefully never have to deal with it, but like,
right.
I would be scared to call them in that, because of that.
Yeah. And in that, for right now, I mean, I would be looking for who else could be there at that time to help be a presence when police arrive. And in Minneapolis, you can ask for a CIT officer. They have specialized training in mental health. And and honestly, I think that a lot of it right now, as we're refiguring out how all of this works in terms of policing and police reform and police everything, that it's part of the risk assessment when you're making the call. That's where I would want to be more involved earlier, and it's a judgment call. Sometimes a family member may be more effective at saying, at getting like the weapon to be put down or something like that. I don't really have a good answer yet, other than trying to be responsive sooner than that. It's not always possible. And there aren't a lot of, there aren't options other than police for when there's a weapon involved and something is actively happening. As much as you can say, this is not a situation that I think is a danger to others as much as a danger to themselves. I think that is something that you can explain. Otherwise, if it's not an active situation, I would be probably more hesitant to call 911 and more ready to call COPE and lean on COPE's guidance as well. And yeah, so it's a real concern, and I don't have a good answer for that.
Thank you. You called it a C, did you say a CIT officer?
CIT officer, yeah.
Mhm. Thank you. Thank you so much.
Mm-hmm.
Do you have any recommendation on how to respond or follow up when you're talking with somebody and you're seeing the signs and you're having that specific conversation or question with them, and they're asking you, please don't tell anybody. I don't want anyone else to know. They're expressing embarrassment for those feelings, and you don't want to make that commitment to not tell anyone to keep them safe, but you don't want to lose their trust in the process.
Right. I think you can say something like, or when you're asking, you can ask that question up with, because I want to help, and say that, I hear that you don't want anybody to know about this. There are a few people that are going to have to know in order to keep you safe. It's after the fact. Many times, I don't know that I have statistics for this, but anecdotally, I think that what we see is that when somebody is when you reach out to services to help somebody, that when they are through the crisis, that they are more likely to be, yes, thank you, that's what I needed. The example that kind of comes to my mind right now, it was not a suicidal crisis as such. I had a person who was who had been who has been suicidal at times, but was not at this point, but was using some significant combination of substances to try to sleep and be able to forget for a while. And I wasn't comfortable with my ability to assess whether or not that could lead to an accidental overdose. And I did call 911 check. They did go to the hospital and get assessed. They did get extremely upset with me. And I had a weekend's worth of more than frustrated emails, which over time, especially once I explained that it wasn't that I thought that you were suicidal. In this case, it was that I was concerned about accidental overdose. Over time, with some repair, they were like, okay, yeah, that was really helpful, thank you. So I think that people come around, and it's a risk that you're taking too. Hopefully they will have somebody else that they can trust if that trust isn't able to be repaired. If they don't survive, they also can't repair that trust either. So, very good question. Thank you. Anyone else?
Can I ask a question that's not specifically related to suicide, but mental health in general? So, and if you are not the one to answer this, maybe you could lead me to someone. If you know someone who is dealing with domestic abuse, in general and specifically during this time, and let's say the abuser has some mental and behavioral issues, what is the best way to go about that? What are resources? And this is out of state specifically.
Hmm. Um, and you're looking to keep the person who is being like, which person are you talking to, and what's the
I mean, that's a great question. I mean, I have access to speak to either of them, but the victim is who I would want to
Yeah,
protect.
you're
But
looking to protect them. I, you know, especially across state lines, I think that even if you go through some of the local domestic violence organizations, that they would have probably be able to connect you with the proper agency across state lines.
in general, is that something that JFCS like handles? Like if there's a local branch there?
As far as if there's a local JFCS in the area where that's occurring.
Yeah, would that be a resource for the victim?
I would believe so. I don't know exactly what the different JFCS agencies have specifically in different states.
I think that would be a good question for the IRC.
Mhm.
You could just call the number for JFCS, which is on the PowerPoint slide, or if you look on the website, and you can talk to IRC and they would be able to give you, I think, a good answer to that question.
Can you see that?
I don't mean to steal either your question, Mark, or Leah's question. For those of you that had questions coming into this, do you feel like this addressed those questions or things that you're wanting to learn? Are there anything outstanding that you would want to see either Mark address now or Leah try to help us with for the future?
And you can always, think about it a bit and reflect on this and what needs might be coming up in the future and let us know. I know we've done like an overview, Mental Health 101, maybe a year or so ago. So I know that's something that we have done and could do again, just as a starting point.
Thank you so much.
Yeah, thank you very much for putting it together. Thank you for your time.
Thank you.
Thank you, everybody.
All right.
Take care.
Take care. Thank you.